Yeah, so this is an interesting and somewhat neglected group of patients, possibly because there's been no progress here for at least 20 years, if not more. This group of locally advanced non-small cell lung cancer constitutes about 25 to 30% of the patients that we see in our cancer centers with non-small cell lung cancer. There are patients who are too locally advanced for surgery, but who don't yet have obvious and overt distant metastatic disease. So these are patients who might be curable with aggressive local treatment, but they're in various stages of fitness. Some of them have multiple comorbidities because of smoking-associated diseases such as chronic obstructive pulmonary disease, cardiovascular disease, and other comorbidities that make it difficult for us to treat them aggressively. Other patients are fitter and perhaps a bit younger, in whom we can entertain the idea of combined modality treatment with chemotherapy and radiation, and in very unusual situations, possibly even then refer them back to the surgeons for perhaps a definitive excision of what might or might not be some active residual disease. So the treatment of this varies a little bit, but basically we're talking about combined modality treatment in younger and fitter patients with a curative intent. Unfortunately, however, cure is only achieved in these patients in perhaps about 20% at most. Median survival is perhaps around 20 to 22 months, depends on the series that you look at. There's been virtually no progress in this for about 20 years, as I said. Combined concurrent chemotherapy with and radiation with the platinum doublet, usually platinum etoposide or platinum and a vinca alkaloid, concurrent with about 6 weeks of radiation therapy, remains the standard of care. It's uncertain whether induction chemotherapy or consolidation chemotherapy, either before or after the radiation, is going to add any value. But for the core element of the treatment, I think, is combined concurrent during the radiation with at least 2 cycles of chemotherapy, platinum doublet, with cisplatinum. Treatment with carboplatinum is perhaps a little bit less effective, but might be suitable for certain kinds of patients who perhaps have hearing impairments, peripheral neuropathy, diabetes, or a fear of nausea and vomiting, for example. So carboplatinum paclitaxel is a fallback in these patients who are a bit less fit, but there's a bit of concern that it's not quite as effective, and there may be somewhat more incidence of pneumonitis with the radiation therapy concurrent with the taxane. So for the time being, the academic standard is platinum etoposide with radiation. There is the possibility to substitute cisplatinum and pemetrexed, as per the PROCLAIM study, which showed equal efficacy to platinum etoposide or platinum vinca, and this is more convenient and somewhat less toxic, but only applies to the non-squamous patients. But that did not succeed in statistically significantly increasing survival, but it seemed to be equivalent, so it's a small advance. There have been lots of efforts to try to improve the situation by increasing the radiation therapy dose up to 74 Gray. Unfortunately, those patients actually did worse in a large RTOG study. To add targeted therapies such as cetuximab, that showed no difference at all. So that's a cul-de-sac, really. Different kinds of chemotherapies, as I say, consolidation. These have not worked for 20-25 years, so we've been stuck. So we're looking for something that's positive. We're looking to different types of treatments, particularly treatments in the immuno-oncologic sphere.